want to spend a lot of time on talking to you about an analysis of the clinical commission priorities across the West, because you've already heard from 3 CCGs eloquently describing the challenges that lie ahead of them. But as you know, probably that the CLAHRC West covers a wider area. We included Swindon, Wiltshire, and Gloucestershire in our analysis, and we produced a priorities analysis report in 2014, partly to help me, who's come new to the area, to understand what was going on in terms of population health priorities, and importantly, what is the NHS, what are we doing about it? To produce a composite picture of priorities across the whole area, and just a brief summary of the methods that we used. But as we finished that work in the autumn of last year, the CCGs produced their 5-year plans, of course. And so what we needed to do was to update the priorities. So we did that thematically, and we found that the priorities coalesced around 4 themes. And we had a number of priorities that weren't universally shared across all 7 CCGs. Now, why might that be useful to you, to have a presentation in tabular form across all of the CCGs? Well, it might be useful if you're looking to look at some of the synergies that are developing between the different CCGs. And if you're a HIT and you're interested in health inequalities, it might be really helpful to look at, well, what are they doing in Swindon and Wiltshire about health inequalities? How have they interpreted the national mandate? And what are they doing locally? Both reports are on the CLAHRC West website, and you can read them at your leisure and contact me if you've got any questions. What I'd really like to do now is to talk about the health integration model approach and the work that we've done at the CLAHRC West. Okay, the HIT model, how does it work? What I want to say right at the start, that we did not conduct an evaluation. What we conducted was a precursor to an evaluation, to inform an evaluation plan, because what we needed to develop was a theory of change. Lots of people are not very keen on theory, but like Kurt Lewin said, there's nothing so practical as a good theory. And I think that might be helpful in terms of the way forward for the HITs. And the raison d'etre, if you like, for the HIT model was whole system working to improve service delivery and health outcome. Now, how do you achieve that? And to develop a theory around what you've achieved in the last few years, I think is really important. Because in order to understand why something works, you need to, in order to do an evaluation, you need to understand why and how something works, in order to clearly link any effects that you describe and observe, how these are linked to the innovation that you carried out. And it's also important to produce generalizable findings to models of the same or similar type. What's also really handy for evaluation purposes is to produce this, a logic model between activities and expected results. And you'll all be familiar with these domains of input, processes, outputs, outcomes, and impacts. Again, this is crucial for evaluation, to be able to describe all these domains in greater detail is necessary to make any sense of what you're doing. What's really important to say at this stage as well is that the oldest HITs are just entering their 3rd year. You haven't been around very long, and to look at outcomes and impact is going to be really difficult to do for a little while. What's been really heartening for me today, hearing about all the work that the HITs have been doing, that there are a huge amount of outputs, all of which have potential to develop into outcomes and impacts. So what was the aim of the study? It was to retrospectively assemble the theory of change underlying the HIT model. We wanted to provide a fine-grained description of mechanisms in which intended outcomes were thought to be achieved, and, as I said earlier, to inform the development of a formal evaluation strategy, or indeed to find a way in which HITs can look at where they are in the life cycle of a HIT, how mature they were, what else they needed to do to propel their work forward. Just briefly about the methods, it was a wholly qualitative study, and we conducted a documentary analysis of 140 documents. They all related to the development of the HITs. The first HITs were established in 2012, so there were a number of documents that related to the steering committee that developed the model. Then there was a whole bunch of documents around the expression of interest documentation and the application documentation, as well as subsequent meetings, etc., notes that BHP kindly shared with us. Data collection period between June 10 and August 14, and I also conducted interviews with 11 people who were closely associated with the development of the HIT model. Just a little bit of background on the analysis. I won't go into that. What I really want to share with you are the outcomes of the analysis, which were the identification of 4 overarching themes, which are whole system engagement. This addresses the question of who was involved, and critically in terms of the logic model that I put up earlier, it looks at inputs and the processes that were involved in establishing the HIT. Collaboration, again, looks at process as well as touches on some of the outputs. This is about how was whatever was supposed to be achieved. Integration was the third theme. I put it down as outcome and impact, so what is supposed to be achieved. But it also has some process issues rolled up to that. You need to integrate in order to achieve an integrated product. And innovation was the fourth one. Again, it answers the question of what is supposed to be achieved and touches upon outcome and impact. Now, you might say, yeah, we know these words really well. You know, we bandy them around everywhere. I hope what we've been able to achieve through this work is to define and clearly describe about what is meant by each of these terms. And I'm going to now address each one in turn. So whole system engagement. It refers to the process of actively seeking to engage all organisations and people who play a part in whatever problem it is the HIT has been established to address. And it's been really gratifying to me today to hear about the work, and a lot of presentations started out with, and we're involving A, and we're involving B, and now we've just talked about C, about this problem as well. It's bringing people together and creating a legitimate place for dialogue. And these are all the sorts of organisations who you might expect to be part of that whole system engagement. So it was facilitated through the process of becoming a HIT. So you've got a very structured application process, an iterative process where there's feedback and from the reviewers, from Bristol Health Partners, going back to the HIT directors, the applicants, and in some cases a dialogue emerged between these stakeholders. And what was really important, and I haven't got time to go into now in great detail, but the structure of patient and public involvement that's emerged in the last couple of years, which has been in development going back much earlier than that. has helped to formalise and more clearly define the input of patients and the public in the HITs. Here, an excerpt from one of the senior participants involved. I would hear commissioners saying, "This is brilliant, you know, I'm able to have conversations with people that I could never access before, and we can get like-minded people in the room together, and we all want the same thing." And I used to sit there thinking, this is what it's all about. This is actually what we were trying to create. And I'm now moving on to collaboration. And this refers to the development of methods that enable partnership working and co-production. And these are just a number of examples of how that co-production was achieved. So establishing structures and processes that facilitate collaboration, and they're very different, you know, around the range of 18 HITs that we currently have. I suppose, you know, the really important one is that co-creation of scientific questions that people in positions to enact change want answers to, you know, working with commissioners, being aware of their priority, what's driving them. Responsiveness to information and knowledge needs and knowledge mobilization for decision making, really important. Another thing was that, you know, the HITs become the show in town about the particular problem that was being dealt with, you know, the place to go. And leadership and negotiation skills are really important in fostering collaboration. Some of these things are obvious about the breakdown of professional, organizational, sectorial boundaries and silos, but, you know, although it's a frequently cited barrier, the experience of actually overcoming some of those barriers and finding a legitimate space in which to talk about common problem was experienced and talked about in very excited terms. There was a HITSO mechanism for addressing translational and implementational gaps. And one of the things that was really important and highly stressed was that of senior sponsorship in the organisations that were supporting the development of the HIT. And then here I've got a quote from a HIT director who said, without sounding somewhat simple about it, you know, relationships are the most important thing in order to keep moving, in order to move anything together in a partnership. So the aspect of one area that's been successful was that the relationship with the commissioners was strong, in the sense of having a common ideology and mutual respect of each other's tensions to deliver it. So when you understand that, you can actually find a common goal that would achieve on it. Okay, now come from the process issues to the outcomes, and as I said earlier, integration sort of sits a little bit in process as well, because it refers to a range of activities which are brought together to maximize benefit, involving existing collaborations, so people who used to work together also came together to create the HIT. It was integrating service delivery and research. It integrated biomedical and population-based and community research. It integrated, or the aspiration was to integrate data in order to produce intelligence on which to act and to inform decisions. I've put integration of health and social care services in brackets because in a lot of the earlier documents that wasn't an explicit aim. It's become more so in the last couple of years. So some examples are around developing and piloting integrated assessment clinics, providing integrated information support and advice to GPs, and bringing together and addressing data gaps to inform service design and delivery. A senior manager talked very candidly about integration, and they said, so moving on beyond the language of collaboration towards a position where organisations are operating in a framework which will encourage them to make decisions on the basis of system benefit and not organisational benefit. that's the journey we're still on. But I think that the fact that we've begun it and we've made that change in terms of language and people's collective development, people's collective collaboration is a very strong legacy of the HIT development work. And the HITs are important in that regard because they are a material demonstration of how that will work in practice. There are considerable structural barriers in the way of delivering on integration because of the lines of accountability, which are organisational. Accountability is to organisations rather than to the system, and that's one of the barriers that HITs, of course, face. Lastly, I come to innovation. So this refers to novel ways of delivering services or interventions through the introduction or application of new approaches, usually to improve quality and to decrease costs. And here are a number of examples. And again, the development of novel near-patient testing is an example, use of technology to increase access to services, piloting of new interventions and services, and data linkage. Again, there is no evidence that this has been achieved. These are aspirational. These are aspirations that were expressed in the development of the HIT model in the application forms that HIT's produced. Finding evidence for the outcomes, i.e. integration and innovation, that will be the task of a summative evaluation. And again, a last quote, the hope is that the HIT work will potentially open up new ways to think about the sorts of interventions that will have real impact. So spotting an unknown correlation might unlock a whole different sort of area of policy interventions that we don't just focus on at the moment. So this is about the sort of thinking that is possible through people coming together to be able to develop really new ways, novel ways of linking ideas to come up with new models of care. That certainly was the aspiration. So in terms of the theory, what is it that HITs do? And these will sound like motherhood and apple pie, but this is all grounded in the data. This is the stuff that the people who developed the HITs and the applicants, and this is what's reflected in the documents. This is what people are passionate about. This is what they want to do. So HITs harness the benefits of collective inquiry, and that can be formal research, but it can also be inquiry. You know what? I'll go and talk to such and such and find out how they're doing things. But what is really important is the inclusion of the stakeholders, including patients and the public. I talked about the legitimate ground for negotiation, and the idea is to find practical solutions. They're not talking shops. They're spaces where solutions and compromises are being negotiated. And HITs facilitate collaborative work to define, to refine, to generate, and to implement evidence. I think that's really important. So in the last few minutes I've got, I just want to briefly talk about HITs in relation to public health and services, and HITs relation to research, and then finally an emerging logic model before we open the space for discussion. So it provides a focus for key health challenges. It's a unique model of collaboration and knowledge mobilization, and it provides a clear pathway from evidence or research to implementation in practice. I'm not saying that's easy stuff, but that's what it is you want to do. It provides a mechanism, and it's a bit of a repetition. It's that evidence to implementation and practice concept. Facilitates the relationship to the NIHR to roll out innovation and exploit potential for wealth creation. Quite tricky to achieve because there's lots of stuff going on and not all of it can be rolled out, but it's starting that relationship with the NIHR. cross-hit collaboration and learning, there was some evidence of that in the early application process, but what I've noticed today, in the way that people are talking about the current work that they're doing, that's what they're wanting to do. They want to collaborate. You're doing this, oh that's really interesting because we're doing that. Maybe if we pool resources or we work together, we can find more common ground to take things forward. Hits in relation to research, close fit with local and regional strengths around what the research institutes, the universities and the region are doing. They provide opportunities for multi-stakeholder research to engage a wide range of perspective. You've got a wider genre of research beyond the biomedical paradigm. And I'm, as a qualitative research ethnographer, I'm really delighted when people talk about, oh, and we've just done a piece of qualitative work, and it's been really insightful to help us understand why the RCT results were as they were. So it's really great about the wider perspective and the different genres of research that have become legitimate as a result of the hits. Facilitates an inclusive research culture and increases the capability and capacity. Practitioners are getting excited about becoming involved in research. Need for negotiation and brokering across multiple agendas and perspectives. I work for the CLAHRC, and it's great to be working with lots of different people who are passionate and interested in research. But it needs some skills about managing expectations and what it is possible to achieve within constraints to resources. Existing collaborative relationships through the hits can provide a competitive edge in the ever more competitive world of research funding. And again, in research applications, hits are starting to work together more and more. My final slide is just the simple logic model for hits on the basis of the work that we've done. So in terms of the inputs, the application process, the central resources and the organizational resources are the inputs, and some of those are some of them are equally spread, and others are not. And in terms of the resources that the applicants, the hit applicants, are able to provide themselves. Some start from a much higher level than others. So in terms of their life cycle, in terms of their maturity, some will need a longer period of development, whereas others are ready to spring into action fairly quickly. Then you've got the process issues that I talked about, the whole system engagement and collaboration. They were clearly process issues that were being tackled in very different ways by the wide range of hits that are currently in existence. Now the outputs are a huge number of outputs, and all of the hit presentations that I talked to today talked about what they were doing, what their achievements are. The translation of those outputs into outcomes is something that we can't really talk about yet because we don't know, and there might be some outcomes that can already be demonstrated and evidenced. Other hits will find that quite difficult, but I doubt whether in 2 years and a bit outcomes can be measurable. And the same for impacts, really. The impacts are probably more likely to be able to be evidenced beyond 3, certainly 5, up to 10 years. So this is the model, David. I don't know what you would like to...
Okay, thank you very much, Sabi, and thanks for putting forward so succinctly what I know is a really considerable piece of work. I'm conscious of where we are on a Friday afternoon, so I don't want to keep you here unduly, but I do want to just create a little opportunity, if there are any questions, to sort of put those now. So has anyone got a question about that work? Okay, I've got one, which is about In terms of publication and sort of next steps, what's the timescale you're working to?
So we're pulling together the paper on the basis of this work, and what I would like to do is to share that work as soon as possible, try to write it up as quickly as possible. What I need to do is to get the consent of the participants we are using quotes from to go into the paper, because I hope, you know, it's difficult to try and hide who people are, but you need enough information in the paper to say, you know, as I said, you know, clinical academic director, you know, people might work out who they are, which is why it's so important that people's words, once you put them in the public domain, are happy for that to happen. But the timeline for that is submission to a journal such as Implementation Science, a number of papers that have been published on evaluation, knowledge mobilization, communities of practice, which this sort of work fits into by the summer.
Great. Thank you very much.